their code status. We have a lot of patients nowadays that have a full code. So if they're on hospice and they're a full code and something starts to happen, we tell them they have to call EMS. There's no other choice. If we're there, we're going to start CPR, but then we're going to call 911 and we're going to expect to have relief. And then they are probably going to go to the hospital because they are a full code. And that's kind of, in my eyes, it's kind of like, it doesn't make sense to necessarily be to be a full code and have hospice, because hospice means end of life care, and people that are full codes are typically saying, I want everything done. So it's our job to work with the families to try to explain what that code status means, and get them to that comfortable point where they'll accept a DNR eventually.
So hospice, at least the Hospice of Central Ohio, is much more of a palliative care organization versus just an end-of-life organization.
Well, I mean, we have both. We have a palliative care organization, palliative care side, and then we have a hospice side. The difference between them is hospice, you do have to meet that criteria of the 6 months or less. But that doesn't mean 6 months or less to me. That's a long time. 6 months.
Right,
is
but
a
you're
really
doing a
long
lot
time.
of palliative care during that 6 months.
Absolutely.
And that's a definition I think some of us really needed ourselves to know, because again, we hear hospice and we go, why did they call us?
Yeah. And hospice nowadays is so much more. I have a patient right now who's still driving every day. He's still out running errands every day. He goes to lunch every single day with a friend. So he's out and about, very, very active. So he wouldn't look like your typical hospice patient. Then we have the others that are what you would mostly see, you're bedbound, not functioning, family taking care of them, not as responsive. So we have both sides of the spectrum, but that gentleman that's driving around and keeps going, his life expectancy is still 6 months or less, even though he is still very high functioning. And he may surpass that 6 months and make it to 8 months. We don't know today. Neither do the doctors. They're just saying it looks like he could pass in that next 6 months. And as he declines, his needs will change based on what's going on. But our palliative care side is more chronic patients that don't necessarily meet hospice criteria, but are chronic pain, chronic CHF, chronic COPD patients that have respiratory issues but don't yet meet that criteria for 6 months or less. Or maybe they're just not ready for 6 months or less. So they're two different sides, but in the hospice side, we're still doing palliative care. All palliative care is pain management and symptom management at the end of, So we are doing palliative in both sides. They're just two separate entities.
Do you coordinate with other social service agencies?
Yeah, I'm often in touch like with Senior Options. We do like Meals on Wheels. I'm often on the phone looking for help for people with financial needs. A lot of it's financial this day and age. Getting people housing, looking for places for their animals because they can't live with their animals anymore. A lot of it's looking for people that need nursing facility care versus home care now, or linking them with 24-hour caregiving in the home.
So would your agency necessarily take the lead in all that?
Mm-hmm.
Okay.
Yeah.
Because of the medical comes first.
Yeah. We're very holistic, so we're looking at the whole person. So we have a team of social worker, chaplain, aide, volunteer, medical director, nurse. But the nurse is kind of at the top, and then we kind of work our way down. But we work as a team. So I might be working on the emotional side, the getting services and that side of it. The nurse is going to be working on the medical part of it, and then our aides in there doing personal care. Our chaplain's doing spiritual care and emotional care as well. So we're looking at it as from a whole person perspective. And going to the hospital and stuff as a hospice patient, hospice only covers what specific disease that the doctor says that patient is going to pass away from. So if we find that they have cancer, let's say it's a patient with breast cancer, then we're covering anything related to that breast cancer. But if that patient also has COPD, they might go to the hospital for their COPD, but not for their cancer. So we look at it, we kind of compartmentalize it so that we're looking at this one basic disease process set, but they might have 6 other, things going on. Same thing with diabetic. If this person has cancer, but they're also a brittle diabetic, if you get a call and something's going on with them is related to their diabetes, it may not have anything to do with hospice.
So them saying that they're in hospice doesn't necessarily relate to why they called us.
Absolutely.
Which is-
It's very similar
Yeah,
to how we treat DNRs,
pretty much,
you know, so.
Yeah, and that's something you're not gonna know. I mean, they're not gonna have a list saying, these are the conditions that they're on hospice for, this is the conditions they're not on hospice for. They don't necessarily have that. Most of our families have no idea what qualifies them for hospice. We try to educate them, but most of them don't understand all those letters and all those diseases. Because we kind of clump them together. So if cancer is their primary diagnosis, if the diabetes was caused from the cancer, then the diabetes and the cancer kind of are lumped together. But that's a lot for you guys. You're not gonna have time to determine all that. But that's why hospice is important, because we look at the whole thing. So if you say call your hospice nurse, our hospice nurse could get on the phone with you and you could discuss that if that were something you had time to do. I think it probably depends how major the emergency is. I'm sure you guys deal with emergencies that are here and emergencies that aren't so emergency sometimes. Does that answer your question?
Mhm.
But I'm sure that makes it hard for you guys to determine necessarily what to do.
Yeah.
You said you're a Hospice of Central Ohio. Are there other hospice organizations in the area that may function under different rules?
Absolutely. We are probably one of 30 hospices in Central Ohio. And I'll tell you that most hospices, probably 95% of them, if they go to the hospital, they automatically discharge the patient. That's it. Then there's a small amount that look at it more, let's see what's going on, let's see what's happening. If we can get you home, we're going to keep you. We're not automatically going to discharge you. But every hospice has the same set of rules when it comes to eligibility.
You mean discharge from hospice?
Mm-hmm. Yeah, patients won't. Almost every hospice, when a patient goes to the hospital, they automatically discharge.
So once they get out of the hospice, they would have to reapply? Re-enroll.
Yeah, because what they say,
Even if it's a condition not related to their hospice care?
even if it's not related,
Whoa.
yeah, a lot of them do that because there's a chance that they could assess the cost for that. So I take the risk if I send one of my patients to Riverside, then if they can bill us for that. So if a patient falls and goes to the hospital, they will automatically discharge because they don't want to be assessed the cost for that. Because then our job is to determine why they fell. If they fell because they're weak because they have cancer, then it's going to be hospice's bill. We had a patient once that fell, and 3 days after they were hospitalized, we found out she fell because she tripped over her pantyhose trying to pull her pantyhose up. Well, that doesn't have anything to do with hospice, but we didn't know that till 3 days later. So that's why most hospices, they will discharge immediately because they don't want to get that cost for that patient being in the hospital. So I would say almost every hospital does that. Our hospice also will take patients that are still getting dialysis, that are still getting radiation and chemo treatments. And as long as the doctor can say that it's not increasing their life expectancy, then we can do that without getting in trouble. The problem is we pay for that. We pay for that $2,000 a shot radiation treatment. We pay for that dialysis, which is very expensive. So, we look at all that, but what we found is that our philosophy is what's best for the patient and family. And so if you always ask yourself the question, what's best for the patient and family before you do it, then you're always going to get the right result. And we feel like it's sometimes best to pay for them to go to dialysis so you have time to work with them and gain that relationship so that we can help them when they can no